5. We have been doing this for a couple of weeks now, and today we have a couple of great presenters ready to show some best practices and what they have been doing at their hospitals and around the country. So we're looking forward to it. My name is Allie Hobbs. I am the current SHS Young Professional Chair, and I do this with the help of Erin Kane, who is the board liaison for the young professionals. So if you don't know anything, do you want to let him introduce himself if he wants to?
Hi, I was just going to say hi. Go ahead, Allie.
Hey. So if you don't know anything about SHS, basically our mission is to improve lives through better health care, and we do that in a variety of ways. One of them being this think tank, so we can all collaborate and hopefully impact healthcare for the better. So like I said, Erin and I are both really involved with the Young Professionals group, but we have a couple of community of practice, including education, academics, clinicals, students, experienced professionals, and us. So if you're looking to get more connected with people in this field that you think would benefit you in connecting with, either join with the link on the bottom or connect with one of us throughout this presentation. So like I said, this is the 5th installment. We have been doing all of these think tanks once a week on Friday. This was a time change, but next week we'll be going back to the 2 o'clock time, and they're all recorded. So if you want to go back and review, you can go back through one of these 4, or this one will also be recorded and sent out along with the slides for today. So today, like I said, we have a couple of great speakers, and I'll let them all introduce themselves when they're going through. But the order today is Vinny talking about the state perspective of tackling COVID-19, Renee, staff redeployment due to redistribution of COVID-19 needs, and Bianca, Emory's telehealth model. So looking forward to it. With that, I will pass the screen, hopefully, to Vinny to share his slides.
Hey, hello everyone. Share my screen. All right, are you able to see my screen?
Yes, it's me.
There we go.
Let's see. I put it on presentation mode. Do you see the presentation mode?
Looks great, Vinny.
Awesome. All right. So hi everyone. So like Ali said, my name is Vinny Montero, and we've been working with the state of Utah to tackle the problem with the virus. So we've been working at it for about 4 weeks now. So the question now that we're trying to answer is, the question so what's on everyone's mind, which is, when can we get back to normal? The governor put together this initiative called the Utah Leads Together, and there are 3 phases to this. So the phase 1 is the urgent phase, which we're now, and there's the stabilization phase, and then the 3rd is the recovery phase. So what I'm about to present to you guys, it's the phase 1. The urgent phase. And it's really about, we're creating this robust process to stop the spread. We're very optimistic about it, but again, we must say that there are no guarantees, of course, and this is moving really fast. We've been working 15-hour days, 7 days a week on this. So, but we're very excited. I'm happy to be sharing it to you guys. The other thing I think I want to mention is that this is a hot topic, obviously, and it's very fluid. And the unique thing about it is that we're learning something new every day. Sudden loss of taste is something that wasn't there a couple of months ago. Just in the past few days, we've seen a couple of articles saying that after some antibody testing, maybe the number of people infected is probably 50 times of what we originally thought it was, and that could change a lot of our initial assumptions. But let's move on. So I'm going to talk to you guys today about the goal, what's the problem, what's the strategy, and us building this machine to tackle this. So let's start with the goal. So the challenge that we face right now is how do we know, that we are in a good place in terms of the virus? How do we know that we're focusing on the right things? So when we started, we asked, of course, people to stay home and social distancing, which it's all important, and I'm grateful that everyone in Utah was abiding, or most people are abiding by those. But the conflict really here is the challenge that we have is if we focus only on public health, then we know the economy is going to struggle, right? But if also on the flip side, that if we focus only on the economy, then we run the risk of having more casualties than we'd like to, or overwhelming our healthcare system. So we needed to find a goal that would be a win for both sides. So the first step for us was to find an objective criteria. And that is, how do we know that we're doing well enough with containing the virus so that we can then go focus on the economy? Now, our focus that we decided to tackle is the transmission rate. So I'm sure you've heard of, R naught, or in a simple way to say is the pass along rate, that anything over 1 is technically an exponential growth. And anything under 1, of course, it just moves it towards 0. So our initial goal is just to get it to 1-to-1 transmission rate, and then get to under 1. But the R naught is, of course, as you know, is a combination of the properties of the virus itself, but then the way the humans interact. So it's a great goal, right? But then the question becomes, why aren't we already doing it? What is the core problem for us? So for us, the core problem, I can move on. There you go. So the problem for us is what we call the iceberg principle, which is really that if you have a ship, if you are a ship on the sea, you only see the tip of the iceberg. But what's underneath is really, what's underneath the water is really what wrecks ships. And this is the same issue with the virus. So let's just say if there are 1,000 cases out there, there could be another 4,000 cases that are not known to the system. So there are people out there infecting other people, and they don't even know that they're doing. They could be pre-symptomatic or sometimes even asymptomatic. And if we're talking about finding these, let's just say 5,000 people in a population of 3 million, it's like finding a needle in a haystack. It's really hard. So for now, the measures of staying home and social distancing is helpful until we know what the true magnitude of the problem and what we're dealing with. So to solve this, we're building this machine, right? It's this process, in essence, of detecting the undetected in a systematic way. So our strategy is simple, of course, not easy, but it's a 3 steps. So first is detect the undetected. Second is move them into quarantine and treat before the virus spread. And then lastly, we continue to monitor and adjust, the social distancing protocol. Now, the project that I'm working on, we're focusing on mitigating the side of this, but there's another group that's also working on preparing for worst case scenarios. Do we have enough ventilators? Is there enough bed capacity for all of this? Now, simple goal, right? Now, imagine finding the one person in this picture that represents the 5,000 out of a 3 million population. Really what turns out to be our biggest constraint is information. If we knew where that person was, then we could do it. So that's that person that I'm looking for. So how do we do that? So the 3 steps for us, like I said, the first one is identifying. It begins with testing. So we can't defeat an enemy that we don't know where they are. So we don't know, we don't want to wait until the hospital starts to fill up and more people die. So we want to test and isolate them quickly. And then the contact tracing begins. So we want to understand what is the point of origin of that infection? Where did those people go? But then on the flip side, we want to know if that person infected anyone. So where could it have spread to if that person was going about their life without knowing? So then the question becomes, that's our plan. So how do we know that we're making a difference in doing this that I'm just talking about? So we created a dashboard that I'm going to explain a little bit in a minute. But this dashboard that we created we're really measuring what we call the core four. So what is this core four that we're working with? It's really telling us if we're making a difference or not. So the first one is the transmission rate, like I talked about, the R naught. And how do we know that it's coming down? Because we want to get to 1.1 to 1-to-1 ratio. Now, the best way that we decided to look at this is new hospital admissions. And why is that a measure that we decided to use? So you can't really look at the new confirmed cases because as we test more people, that the number of confirmed cases will go up, and it doesn't mean that the virus is spreading or anything. It just could mean that we are doing a better job of detecting the undetected. So we realized that just the new hospital admissions is a good measure. The second one is the hospital capacity for the state. So looking at the hospital bed utilization for the whole state, and then the ICU bed utilization, how is that looking? Because also, one of our main goals is not to overwhelm the system. Now, the next two, it's more of an operational measures. So the first one, we call it the effectiveness rate, and it's really how well we're doing in our tracing efforts. We want to identify the people that are under the water line, like I mentioned earlier. How well are we finding these folks? Identifying the people at risk and then testing them. Now imagine right now we're finding, let's say, 100 people, and there are another 400 people out there. We need to have a machine that's capable of supporting that goal of 500 people identified per day. And imagine, for example, different states have different ratios, but we're sitting at around tests to positive ratio about 1 to 20. So if that's the case, then we need to have a system in place to handle about 10,000 tests a day, which is obviously no easy task. So that effectiveness rate is an important one for us. Now the last one is the identifying the points of origin. So really we want to be able to find out, where is it happening? Is it person to person? Is it healthcare? Is it coming from travel? Where is it coming from? So that's our goal for us, these core four. Now we created this dashboard, as I mentioned, and we have targets on the tests and where, on PPE, and everyone to focus on the same goal. I'll go over a few things that we're looking at. So we're looking at PPE and make sure the state has enough PPE. We actually were able to come together all the major healthcare systems in Utah to tell us about the ICU beds and regular beds, mobile testing sites. We're connecting with the labs, the transportation, how many people are coming in the state, not just from driving, but also through the airport. And then lastly, we have not only an online survey that people can take and then go get tested, we also just launched 2 days ago a mobile app where people can understand how, if they're feeling well, where they can get tested. If they come in contact with someone, we can look back at the tracing efforts. Now, this dashboard is all good and well, and the question is, we have this strategy, we have these measures. Sometimes though, we look at measures and a dashboard as if, buying a scale and weighing yourself every day will make a difference. It's really the diet and the exercise program that makes the difference, not just weighing yourself. But some organizations, tend to get caught up on data. And, of course, us engineers, we are definitely guilty of that. But the question really becomes, how do we make this happen? How do we make this real? So we created this system map that is really to show how all these things here come together. And really, we are not so concerned with each of these steps, but really the flow. The flow is the most important thing here, and we want to work on see them working well as a whole. And answering that question, like I said, how well are we detecting the people at risk, and then have them tested? Because testing for us is a precious resource. Utah is very fortunate to have more tests than what we're actually able to test right now, which is a good problem to have. But a couple of features that I want to point out here. One of them is the intelligence portal that you see. Now, this intelligence portal is helping us have the information to help find those people who are at risk, create heat maps to know where the virus could be spreading, so we can get ahead of the virus. So there are 4 components to this intelligence portal. The first one is the contact tracers. These are like the army, the foot soldiers, these great people who are like in the front line. They're calling people, they're sometimes visiting them, making phone calls to see who you may have been in contact with. This is an army of like 1,200 people who are available to do this. However, that's not enough. We also have an online survey, as I mentioned, where people can, schedule their testing, and this is aligned with the Department of Health, and it's just another tool to help people go get tested. The third thing we're doing in the intelligence portal is large-scale testing. So there's a lot of speculation, as I mentioned, of how many people are actually infected, and so we want to find out where the hotspots are. So we connected with the major universities in the state to run these large-scale testings, so we can understand a little bit better, not just where it's happening, but even, let's just say, where should we put another mobile testing site for people to go. And the last thing on the intelligence portal is the app that I mentioned. So having a survey, having people have an easy way to schedule it, a heat map, easy communication with the contact tracers. But it is, again, just one more tool in our arsenal to fight this. Because the question really becomes how to have the right information to make the right decisions at the right time. Now, as you can probably know, if you've been like watching what everyone else is doing, this is really not anything new, right? I'm sure you've heard of some of these efforts. What we're working on here is to operationalize it, scale it, go faster, and just making sure that everything is working together. Because obviously, as you can see, there are a lot of moving pieces trying to come together for the greater goal. Because in a crisis, speed and the operational agility can impact the outcomes. And it's just been, frankly, what the whole team has put together is just quite incredible how they've been able to put all this in one place. We are just now finishing this machine. As I mentioned, this 10 pieces of the machine, we just now finishing it. And it's almost like building a car. We now have all the parts in place. But now that we have this infrastructure, is about like, how do we manage it? How do we improve it? And how do we make it better? As you can see here, we're looking at expanding call centers, making sure we have the right PPE supplies, everything there. It's all coming together. We're pretty much done with all of these steps. So again, at the end of the day, this is what we're doing. We're finding proactive ways to identifying the people who are at risk. We're moving those people to testing quickly and testing them with the right protocols, of course. And then lastly, we're having some strong quarantine measures and isolation to make sure that's happening. Now, I must say, so this has been an initiative that we have the private sector and the public sector coming together. We've seen the county level work with the state level. All the healthcare systems are open and willing to connect their data and share it. It's great to see everyone, focused and disciplined and just relentless to work together to tackle this. So really, especially for the government, seeing how quickly they have moved, it has been quite exciting to see everything. All right, I wanted to leave some time for questions. So if anyone has questions, I'd be happy to answer.
Yeah, and you can either put those in the chat, or I've muted most people. You can always mute yourself and ask a question yourself as well. Either way. Really great work, Vinny, I have to say. That's not to get political, but I wish our state was taking a similar approach. Here in Georgia. Any questions from anyone, either in the chat or unmuting yourself. We've also used the hand raising feature in previous weeks if you want.
Oh, sorry, I just see a question. Have you heard anything about what sort of organizational structures, tools, and protocols Utah might implement to monitor more long term? Yes, actually. So I think another thing that Utah is doing a great job is being very transparent with with the Utahns. So actually, online it's you can just go to their website and find they have the 3 stages that I mentioned earlier, and the last stage being uh, the recovery phase. They have laid out a whole plan of how that's going to happen. So absolutely.
There's a question from Renee. How does something at the state level differ from something at the hospital or hospital system level?
So absolutely. At the state level, as you can probably notice, we are trying to pull together uh, something from, like from the Department of Transportation, from the labs, and bringing all the systems together. I think one of the major differences that like a ton of our conversations is like, what is the public's perception of what we're doing? So I can't tell you how many meetings I've been for hours on the conversation of the app alone. Because imagine 2 hot topics, right? Government releasing an app, which the conversation is, Big Brother 1984. And then you have another hot topic, which is location tracking. And you put those 2 together, it's just a great combination of like major concerns from everyone. But the goal there is just like, how can we have everyone just go back to life into their new normal? I would call it.
That's great. Any other questions?
Vinny, what do you think out of putting together the car pieces, what like piece of that car was the biggest chunk of work that you had to do, or the biggest challenge?
I I think frankly the legality of everything is the hardest part. Um, I was actually impressed how well, let's just say, Intermountain and University of Utah wanted to work with the state and just share data and come together. That was pretty amazing to me how easy it was. uh, but I think making sure all of the privacy and protecting the people, I think that has been like the biggest headache in bringing that together.
Awesome, thanks.
Yeah, Eddie, I think you were one of the call-in users also. You must have called in separately, so I unmuted all of those, so you should be able to say something now.
Yes, can you hear me? This is Eddie.
Yes.
Awesome. Hey, Vinny, awesome work, man. My question is kind of like 2 parts. Number one is, being that your specialty and, it's the theory of constraints. So I wanted to understand if you use that kind of like that approach that you would use from a theory of constraints standpoint to this approach, or if it was more like a project kind of like management more kind of thing. And as the second part of the question was, and maybe you said this and I missed it, was did the state reach out to you guys? Because this goes back to Aaron when he said, I wish our state was a little bit more proactive. So did they reach out to you, or was this something that you already had a relationship with them and you engaged them in this? And awesome work. I'm pretty sure we'll talk more about it offline, but I just had those 2 questions. Thanks, man.
Yeah, no problem. Yeah, so this was definitely as you can probably see, there are like 100 moving pieces here, but definitely it was a theory of constraints approach. The leaders, one of the leaders in Utah is a big believer in this. So she understood that even though this seems like a complex problem, there has to be few key leverage points. And putting this in simple terms, like what is the key leverage point? What is the constraint here? So the bulk of the work in the beginning was having everyone agree that the testing and tracing and identifying, detecting the undetected was our major constraint. That's really from like, we didn't start anything until we had a clear definition of what was the major constraint on that problem. Going to your second question, yes, we did have some relationship with some higher ups, in Utah. They had, we have done work with them before, so they reached out to us immediately once this was happening. Um, I wish, I am in Massachusetts now, and I'm from Texas. I wish one of those two states would like call us, and, so we can work with them because there's so much need there. But it would be awesome to work with more states for sure.
Awesome. Thank you, Vinny. I'll talk to you more later.
Okay. And there was a question in the chat from Jim Benion. He said, good work seeing similar strategies in other states. Are you putting anything in place, a seatbelt in the care analogy, to detect when the opening up leads to a resurgence of COVID?
Yeah, it's a great question. So absolutely. So we actually created this dial, which is taking a lot of this data. One of the important ones being the transmission rate, because like I mentioned, we don't want to overwhelm the healthcare system, and we want to make sure that our transmission rate stays below 1 for sure. So this dial that I'm saying is like from green to red is as we release like the social distancing measures and everything to the people, we can continue to monitor everything from the hospitals and all of that happening, the testing. And if things start moving in the wrong direction, then we can just go back and be like, guys, we need to slow down instead of start keeping opening up. But the goal is to definitely like open up a little bit, see how it's going, then open up a little bit more, see how it's going. So yes, there is a whole plan in place for the seatbelt.
Great. Thank you, Vinny, very much for presenting. That was great, and great questions from the audience as well. We're gonna move on. Thanks, Vinny. We're gonna move on to Renee. I believe I've already made you the presenter. So in order to share, you just click the third button from the left along the bottom there, the one with the arrow pointing up, and then it'll ask you what you want to share. There you go.
Oh, hey, sorry. Okay. Hey, everyone. All right, let's get started. So, my name is Renee, and I work at Emory Healthcare in Atlanta, Georgia. And for the past several weeks, I've been working on a project at the system level where we have been creating an entire staff redeployment office due to, we realized that due to clinics closing and redistribution of needs that we kind of forgotten about everyone needing to find work. So we stood up this entire office within a couple of days and began redeploying people. And I tell you how we did that, and would love to learn more about what other people have been doing at different health systems, and we can discuss the best practices and stuff like that. So the agenda is first that we created, I'll tell you how we created this office in less than a week. I'm actually pretty impressed with ourselves and what processes were needed and what technology was needed. Also, some of the opportunities and kind of some of the silver linings that revealed themselves during this process, and the benefits. I wouldn't say the pandemic is a good thing, but I would say, as an optimist, we kind of have revealed some good things that we are now capitalizing on. And then finally, stories from the field about employees who are being redeployed and what kind of lessons we've learned from redeployment. So first, day one was panic. We realized that we hadn't even thought about all these employees who were out of work, who were using their paid time off PTO. And so we're just, thinking, how are we even going to do this? We should have created this office yesterday. We need to do this as soon as possible. Who do we need? Who needs to be on this team? And so day one was definitely kind of like a mass panic. And then, wait, we're calm. We realized that we actually do have something related to staff redeployment, especially at the system level. And when I say system level, I mean Emory Health is a network of 6 hospitals and numerous clinics across Georgia, and the system being all of those as a whole. And so we actually have something like this that works around the clock during normal operations called Enterprise Staffing Pool. And during normal operations, if a nurse or something needs to go on leave, their unit contacts ESP, and ESP has a whole horde of nurses that work part-time, and they are on deck and ready to go. They have all these templates and processes already in place, and they're experienced in redeploying people across a healthcare system. And we used them, we reached out to them and brought them in and said, hey, can we work together and piggyback off of the processes that you guys already have in place? And they're like, of course. And so that was basically 80% of the work was already done. We didn't have to reinvent the wheel or anything. So that was great. And then we had to then understand what was that last 20% to fill the gaps. So that was kind of what day 2 was. So on the left, we have Enterprise Staffing Pool. This is what they have already in place. And so we need to figure out what is different about new staff redeployment during a pandemic. What would that need? So normally, Enterprise Staffing Pool, they have these skilled part-time employees on hand, and they're mostly nurses, and this is kind of their main duty. But for staff redeployment, I mean, this doesn't happen every day where you have pandemic and clinics closed and you have administrative professionals and MAs and techs and phlebotomists and clerks and all these different kinds of people that all sorts of different skills and licensures and experiences who are now out of work and now need to find different kinds of work. And so we kind of realized that the staffing pools for ESP and for SRO, or Staff Redeployment Office, were different. And that we realized that we needed a different way to collect all of those people, all of those staff into a different pool. Hopefully it's electronic. You know, let's create a different pool for them and work differently from ESP. We need people that are dedicated to working this office, just like ESP has dedicated professionals who work to match requests to employees day in and day out. We need those people on our end, and we need to train them. What do they need to do? What processes do they need to follow? And so we realized the gaps. So we realized that we needed a tool, and we needed staff to staff the SRO. And so by day 3, we had some very competent programmers in our HR office who created an entire staff redeployment tracker in 3 days, and they worked their asses off to create this. It's our EHC staff redeployment tracker. And it pooled every person who was seeking redeployment, who was working time or who had lost their job, for the time being, and pooled all of them, and automatically has all their licenses, their job families, and their skills and all that information ready to go. We also have a pool, if you can see on the top left, the top right, request lookup. So we have employees, we have requests, all in one area, one place, so that we can have people match all those requests and those employees. And so we were ready to go. We got this tool up and running by day 3. And then finally, day 4, day 5, we create our processes. We created a system level process that could then fit into our local processes and not disturb the local staffing processes. If someone at the local level couldn't find redeployment, then they can then go up to the system level and find redeployment there. We create training manuals so then we can train our staff. We found these staff that could work the SRO. We trained all of them up, and we did all of this in 5 days. So that was a huge win, and train them all up, and then we were deploying people within 5 days. And so I think that was a great thing that we were able to do, and a great win. So now I'll kind of go into some of the opportunities and some of the good things that were not just necessarily the straight redeployment piece, but we were able to implement DMS straight away into our SRO. We created huddles and tiered huddles, so any escalations that we had. We immediately escalated them. We created standard work. At Emory Healthcare, we have been kind of fighting an uphill battle to create standards and create standards that all of our hospitals and all of our hospitals follow, and that we can work cohesively as a system. But with SRO, we created all of those standard operating procedures right then and there. So to create an example of what standardization and quality assurance would look like. We tracked our metrics. We made all those things were tracked, and kind of created the example of what we would want in a lean and mean machine. So that was a really great moment when we realized that we had the opportunity to create a standard, the golden example of standardization at Emory Healthcare. So that was awesome. And then finally, some stories from the field of what, once we created the office, did it work? We have some stories of it working and not working. So there was one example of one of our hospitals that needed a lab tech for 3 months. And, you know, at SRO, we were like, what the heck, 3 months? That's so long. And they needed it for weekdays and weekends. And after 3 days of deliberation, we finally found someone who could work 1 month on weekdays, and we set them all up and everything. And by the time they were ready to go, it turns out that that hospital had actually found someone to find that request, fill that request. And that was extremely frustrating because we had gone through that entire process and they hadn't communicated with us properly that they were going through that process, and they had found someone. And then not only that, a week later, they actually realized that that person was not qualified for what their need was. And so this shed some light on a potential improvement project, at least at Emory, where, you know, our hiring process is, the communication is not up to par perhaps, and that the communication between a system level hiring and local hospital level hiring should have been stronger. And so in the future, we'll probably strengthen that. The next one, I think I'm running out of time, but this one was that.
No, you're doing great, Renee. You have till 3:45, so you're doing great.
Okay, great. So this was another example of that many staff across Emory didn't really even know that they were in the staff pool. And it turns out that their managers, their local managers, hadn't even told them that they were in the staff pool. They had just said that they were available whenever, however, and it's actually much more complicated than that, especially that COVID has made availability more difficult, especially with things like childcare and transportation. In Atlanta, we have a public transportation system called MARTA, and with COVID, it's affected the schedule, and so that's definitely affected the availability of transportation for staff across the Atlanta metro area. And so something that I think that we might have or should have thought about earlier was making these availability details more robust. I don't think that we had really thought about, that someone might be available on a Tuesday one week, but then not be available Thursday, Friday on another week, that their availability could be very fluid. And through our process, we had expected that people to update their availability every day, and that it became very difficult. And so we realized that probably in the future, if hopefully, you know, crises never happen again, but that our process can be more fluid and accommodate for schedules and availabilities in a much more organic way, even though that is very difficult. And finally, a good thing that happened from this was that rapport between the system and the local hospitals is actually improved, at least in one way. So we created our system level process through this system level staff redeployment office. And there was one hospital who was struggling with following the system level process and wanted to see if they could just do it their own way. And I think before this time, we would probably just said, yes, just do it, but we took this opportunity to say, no, sorry, the system level has created their own process. Everyone else, every other hospital is following this process. We are upholding standardization and making sure that every hospital does it the same way. And so we compromised really that in a good way, things weren't lost, that nursing roles wouldn't be fulfilled by SRO, that they'd be fulfilled by a different process. But in that way, the standards were upheld, and the relationship between the system and these local hospitals was preserved, and that is definitely the road that we want to be going towards as we move towards greater standardization, but also keeping good working relationships with our local hospitals. So final thoughts, there was definitely great success with redeployment. We created this office very quickly and competently, and we redeployed dozens of employees across the system. And now we have a redeployment process and office, and it's ready to go for when, God forbid, another crisis comes up. And we have set the stage for building a greater working relationship with our local hospitals, as well as shed some light on some potential projects as well. So yes, thank you. And now let's discuss. I'd love to hear what everyone has to hear or say about perhaps their own staff redeployment at their own health system. So thank you.
Thanks so much, Renee. If there are any questions, again, you can put them in the chat, or you can unmute yourself and ask. We have time for maybe 1 or 2 questions. Okay. I'm not seeing anything come through. I'm going to go ahead, Bianca, and make you the presenter. So you can share your screen just while we're seeing if there's any other questions or any questions.
Give me 1 second.
Okay.
Okay. Great. So
thanks again, Renee. Thanks for presenting. Really great work.
Okay. Great. Thanks. Hey, everybody. Good afternoon. My name is Bianca Garcia, the quality manager for transplant. It's nice seeing all those familiar names. Hi, Erin. I hope you all on the call are doing well and staying safe. Also with me is Ryan DiMartino, our management engineer supporting the transplant center. So he'll be unmuted as well and kind of chiming in. There he is throughout this presentation. And to clarify on the title, we'll be sharing kind of a summary of telehealth at the Emory Transplant Center in particular. So we both work for that section. And please ask any questions throughout in the chat or otherwise. So, we have this big sense of urgency that rolled around, obviously, with COVID-19. And for us, that date was actually Friday, March 6th. So, at that point in time, our system, Emory Healthcare, which, is in Atlanta, Georgia, had not made any official changes or mandate to cancel appointments or really have folks work from home or anything like that. But we have a transplant population that is very immunocompromised. And so for us, it's extremely important that we try to keep our patients as safe as possible, as soon as possible. So, that Friday, we just immediately started to cancel appointments for the following week. It felt like the walls were burning around us. People are calling in. We've got staff members wondering about working from home, all of these things. And so, myself and Ryan and one other team member, Chris Perfetta, we're all tasked to work on telemedicine. So how can we get our patients being seen, getting follow-up care as soon as possible amidst everything that's happening? Fun thing, we don't actually have any telemedicine in place right now. It's been something that the center's been wanting to do for a couple of years and starting to talk about. And really, this was our impetus for change and just kind of throwing ourselves out there and saying, okay, we got to make something happen ASAP. So a pretty strong reason for action. So we wanted to continue, again, providing services to our transplant patients virtually as much as possible. So for us, that meant using Zoom, which is something that every team member in the organization has access to create a virtual clinic, to have that platform. But we also quickly converted all of our appointments to phone call visits first. And then we also have this ability to use Doximity, which is an app that masks your personal phone number and lets it look like, a patient's being called from the transplant center, as well as encouraging physicians to use FaceTime and those sorts of things if needed. So we really had these 4 things, and we'll kind of dive into the Zoom virtual clinic a little bit, because that's the main platform that we designed to mirror the clinic space. So, a week kind of passed of just like chaos and things happening and getting, things set up. And then we really started to get together, on the 15th of March and really start implementing telehealth. And I'm just going to be very honest, we just kind of put it together. We would like to design for sustainability. We're kind of at that phase now after having done it for a few weeks. We want to look back and really start doing process improvement. And we really just started at that point in time. So we'll cover a little bit around the process design that we started with and are using, just quickly cover training, and then talk about telehealth visits and the outcome of what we've been working on. So I'm going to kind of zoom in here. So we have, new patients, established patients, people who are coming in and getting evaluated to be candidates for transplant. All of those different groups kind of came online at different times. And this main process map that I'm going to just kind of quickly cover, I'm not going to go step by step, but just to give you the flow of all of our telemed, really applies to a majority of our patients. So I'm just going to kind of zoom in here a little bit. So essentially we have coordinators who are involved on our program side, and they work with the patients pretty much throughout their journey. And so that coordinator team is helping us to even identify the patients who are going to be coming in for who are going to have a telemed visit versus in person. And then we've designed a Zoom prep team, which has some of our team members who are admins, schedulers, patient care coordinators who've been kind of redeployed to help us in this arena to call patients and prepare them for the Zoom visits. Our patient population is sometimes also older and not as tech savvy. And so we're trying to provide this kind of like concierge service to help patients be ready and know what to expect and answer questions before their visits. And then we've really kind of designed this model to be an LPN-driven model. So very similar to what we do in clinic, where an LPN helps to kind of do intake for our patients and room our patients and that kind of thing, and then they go see the provider. So all of these groups have been involved in this process. All of them have had training in different, processes for each team. And again, we're kind of at that point now where we're doing tests of change within each of those groups to try to improve our efficiency, because right now there's just a lot of emailing, right, and a lot of going back and forth, and really trying to make sure that all of the patients are getting what they need right now. So we're very in the weeds, but we've been doing this process for a few weeks now, and that is kind of our main process. The other telemed process that we designed using a Zoom virtual clinic is for kind of more multidisciplinary teams. So we have a liver tumor clinic, and then when we see patients for evaluation on our living donor side, so patients who want to donate their organs to their loved ones or others, we have multiple providers or specialties coming in to see those patients. So it's not just a one doc, one nurse sort of visit. It's like multiple doctors, multiple folks coming in and out of this virtual space. So we designed this process where we can have 2 clinics running at once and have these providers going back and forth, seeing different patients. One thing I want to highlight, because communication is really key, is we've been using the Microsoft Teams platform, which has actually been really great. The chat feature in there is an instant messenger, and we've got a couple teams running now that have just, it's got nephrologists, social workers, financial coordinators, everyone's kind of in there. And when the day of clinic arrives, then they're able to just real time communicate through there, say when somebody's done, when they need the next person to come in the room, that sort of thing, which is a huge step up from what we've been doing in our clinics. So I think that's something that's going to stay, at least for now, for sure. So we've had some success doing kind of this multidisciplinary virtual clinic, which I really think is kind of the highlight of all of this work. Just real quick on training, we've done, I think that number is actually incorrect. We've done 75 like support team members or non-physicians, and about 35 docs and folks who are seeing the patients with that licensure. So all of these folks have been trained in Zoom. And we've really been, myself and Ryan and Chris, we've really been like very hands-on in training and tech support, just because that's what the need was. So we're kind of, again, at that point where we can start to focus on doing some more process improvement as these processes are now going and people are getting more familiar with how to use Zoom. Okay, so onto the data to show kind of our visits and trends. So that blue line is audio visual, which is what we refer to when we're talking about the Zoom clinics or using Doximity. And so, our goal is really to just convert as many appointments as we can to audio visual so that we can provide, the best care possible. And the docs want to be able to see patients, patients want to be able to see docs. We do still have in-person visits, which is that orange line that you see there. And we're trying to keep it down, but we do have patients that come in for infusions for the immunosuppression that they need. So some of that we just can't really get rid of, but we are still trying to convert as much as possible so that we can keep everybody with as little physical contact as possible. And then just going to highlight some barriers and successes here. So, when this all happened, there were already appointments on the books, right? So it was a bit of a challenge being able to work across the different teams to identify which patients should come in, which patients really shouldn't come into clinic, which ones can be Zoom. So we've been working through a lot of that with our teams, and we actually created this. This is just a little visual management that we use, but a process control board so that we could see across the different organ groups who's able to get those appointments identified, because we were talking like, 30%, 40% of appointments are identified. So we don't know about everybody else. And we need to make sure we can contact those patients in advance and make sure that they're as safe as possible in those appointments. And so that's also a success, is once we started using that process control board, people started to do better, I guess because they knew they were being watched. But we also got a couple of people who said, I don't know how to do it. And that's exactly what we want, is to catch those questions and folks. Some other barriers: patients and provider familiarity and comfort with the virtual platform. There aren't not everyone's tech savvy, right? So that is definitely a challenge, but we address it with patients and really try to work with each person through that. And I think it's really great that a lot of our team members are starting to become more familiar, but that was huge. Alignment of communication across all of our different groups who connect with our patients. We've got multiple people at different points. So again, this is like a good next step for us, is to figure out how to have one more unified message to communicate to our patients, because they're getting calls kind of left and right from different groups that are trying to help. And then that Zoom prep team that I mentioned that calls the patient ahead of time, we've been using them for a few weeks, and now it's time to really evaluate if we still need to do that, or if we can even catch the patients earlier in the process. So I think that's really great for us. And so just to wrap it up on successes, we've gotten different team members online across the center. Again, want to kind of highlight those multidisciplinary teams with liver tumor and kidney living donor, because it is a more complex environment, but those teams have been fantastic in communicating. And again, I think, we have a block schedule that we've actually designed, and that Microsoft Teams chat, man, it's done wonders for us in communication. Heart and VAD clinics are online, hepatology, which we also serve, and then all post-transplant patients across the groups. As you saw in the data, audiovisual is now a majority of our visits, so we do consider that a success, and we're definitely going to keep improving. So that's it for my presentation. Please, what questions do you all have?
So I have a question, Bianca. So with the audio visual as a majority of your visits, you know, there's a lot of benefits to that. Even beyond this pandemic, do you feel that your team will continue to pursue that as the primary means of having these visits?
Primary means, I don't know about primary, but we definitely do want to keep using it to support our patient visits, because we've got folks who are like a few years post transplant, otherwise healthy, but coming in for annual visits, for instance. You know, those are
right.
Candidates.
And I think one of the barriers we maybe like intentionally didn't put up there, but there's the whole out of state thing, because we do see a lot of regional patients, and the telehealth stuff sort of gets really messy there. So that's another major reason that we wouldn't like switch wholesale.
Yeah, for sure. I do think we also have another platform that I think is coming online in a few months, American Well, if anyone's familiar with that. That was kind of, it has been in the works prior to COVID-19, like discussions about that. So I don't think Zoom itself will be the platform. I might be overspeaking, Ryan, you let me know.
No, I think that's correct, and I can't wait to do this all over again.
Yes. Great, other questions?
Bianca, very great work there. Great to hear from you, and great to hear all the great work. So the part about identifying the patients, there's obviously the piece about, you know, patient safety and who do we not want to come in. And I did not hear a lot about their comfortability or their expertise with the technology. So, you know, some patients, you know, I love your process map there, how the team is helping them get Zoom ready, but how did you think some patients were going to pick it up easier than others? Did you take that into consideration also with the providers, because you also mentioned here the familiarity and comfort with the virtual platform with the providers? So how did that come into play with selecting the providers on the patients for at least for the trials?
Yeah, great question. So we definitely took the early adopters first from a physician standpoint. We have a couple of physicians who really want to do telemedicine and are like, this is the way transplant's going to be forever, so we better get started now. You know, they really want it. So we started with those sorts of folks first, and then kind of got some other folks involved as we started to ramp up a little bit and they got to see it. From the perspective of patients, I know there's a lot of back and forth communication going on around identifying those patients and working with them individually. So, you know, I do know that there was feedback like, oh, this patient of the appointments coming up on Friday, for instance, these patients we know are tech savvy, or, you know, they've expressed an interest and that kind of thing. So a lot of just those sorts of detailed information coming through. And then the coordinators and physicians, you know, are making that decision to then say, these patients are going to be, you know, these 5 patients, for instance, are going to be telemed. So that's kind of how it happened.
Great, thank you.
Yeah,
great work.
Thanks. What were the question here? What were the barriers to starting up telehealth before COVID? That's a great question, Ryan. Maybe you might be able to answer that.
I think part of it is like it's so many things, right? I think part of it's some clinicians like reluctance to move some of their patients, right? They would only identify a really small population they wanted to do telehealth with until they got thrown into the deep end, basically. And then, you know, I think the laws, like all the laws around all of this stuff is a huge barrier, gigantic, especially for us. And I know you'd be kind of similar, Renee. Like you guys see patients from a lot of different states as well, and that's still a huge issue right now, even in the midst of this crisis. So those are 2 major ones. We didn't have an official platform, right? We're using Zoom, and it's not really set up for it. We just kind of, the 3 of us kind of got together and cobbled together a process that mimics the virtual clinic, but it's not really designed to do that. So I think that all of those things, the general comfort with technology, all of that stuff has been so many barriers. But when you have to figure it out, you magically find a way, right? So.
Yeah, and I do want to emphasize the fact that physicians don't want to let go of seeing their patients in person. We do also have patients that are 10 plus years post-transplant, and at that point, we don't really need to see them in clinic. They're fine. They can be taken care of by community providers, but there is still a lot of resistance to do that. So now telehealth might be that stepping stone to say, well, let's ease up some of the capacity issues we have in the clinic by still seeing them, and then you can do a telemed, and small changes like that may be the way to get to name of the potential new telehealth platform. That's American Well, and Ryan, I don't know if you can type it a certain way.
I'm not sure. I think the app is called like Amwell or something. I downloaded it on my phone. Yeah, the app's called Amwell. You can check that out. I don't know how to get in there right now. I just downloaded it to kind of see what the intro screen and stuff like that is. But we aren't using it yet.
Okay, so we're at time. Thank you so much, Bianca and Ryan. That was really great. Allie, I think you were going to close us out. I know we're a minute over, but we'll just quickly wrap up.
Yeah, thanks again to all of our speakers today. I think this is another great think tank. I just want to remind everybody, next week we're going back to the normal time of 2 p.m. And right now we have Dr. Fullerton on the schedule to present, and he'll be talking about using a phased approach to stand up the system, getting back into or preparing for what it's going to look like on the other side of COVID and how we're going to stand the system back up. So looking forward to that, and thanks again for joining us, and we'll see you next week.
Thank you, everyone. Thanks to the presenters and everyone that attended.
Thank you very much.